Dr. Scott Rifkin, and I'm your presenter for today. Our topic is very timely. It has to do with how we can help facilities navigate the nursing shortage in nursing facilities now and use value-based programs like iSNPs to help them do that. So the official title of our program today is Improving Quality Care Amidst the Current Nursing Shortage and how iSNPs can be of help. We'll talk about what an iSNP is. We'll talk about how an iSNP can be of help to you. And we'll talk about value-based care in general and the tendency of government to push towards value-based care. So let me give my background a little bit that may be of help. I started as an internal medicine doctor in Baltimore, went to George Washington University School of Medicine, practiced in Baltimore, had a part-time job as the medical director and the primary care doc in a nursing facility. And then one day, the Secretary of Health of the state of Maryland decided I knew how to turn around troubled nursing homes. And so for the next 15 years, I helped the state of Maryland turn around troubled nursing homes and eventually got hired all over the East Coast. The folks at Sunrise and Manor Care all hired me at various points to help them with troubled facilities. Even the city of Nashville hired me at one point to do that kind of work. In 2003, I had the opportunity to buy a nursing home, and we built that from 1 facility to 21 facilities and 4,000 beds. Those facilities were in Maryland and Pennsylvania. We had a quarter of all the nursing home beds in the city of Philadelphia, about 1,200 beds. So I've been an operator, I've been a medical director, I've been a turnaround guy. And then once we owned the nursing homes, we started looking at value-based care. And that's how I became involved with an iSNP called PPHP. We Provider Partners Health Plan. And we formed that in partnership, and we'll talk about with another operator here in the state of Pennsylvania. So what is Provider Partners Health Plan? Let me get that over, and then we're not going to talk about PPHP anymore. We're going to just talk about iSNPs in general, institutional special needs plans in general. They're a type of value-based care. They were created by the U.S. government. They're under something called the Advantage Plan regulations of CMS, okay? And they allow a plan, and the plan can be operators getting together, or it can be a big plan like United Healthcare, to hold an insurance license, get the premium that the government pays for care, and then spend those dollars on the care of the patient. And the reason the government does this is they believe it incentivizes operators to do a better job of keeping people healthy and out of the hospital. And what's really remarkable at iSNPs, they've looked at a lot of different kinds of value-based programs. BPCI programs, which are bundled payment for care programs, and other programs, the ACOs. And the one that's really worked well has been the institutional special needs plans. There have been a bunch of studies showing that hospitalizations go way down, that patients do way better, they stay in the nursing home and not in the hospital, they live longer, healthier, happier lives. It is a huge push by CMS to get all Medicare patients into value-based programs. On a national basis, about half the Medicare patients are in something. Either a community advantage plan, an iSNP, a BPCI program, an ACO, and clearly the iSNPs have gained favor. They're no longer test programs. They've been made institutional within CMS, and they'll be around for the foreseeable future. So these are, again, they're a type of insurance plan. Operators can own them and operate them themselves. And in our case, with PPHP, we hold an insurance license from the state of Pennsylvania and approval from CMS to run the plan. We were founded by 2 Pennsylvania nursing homes groups. One was my company, Mid-Atlantic Healthcare, and the other was Quality Life Services, which has multiple facilities in Western Pennsylvania. And you are familiar with that organization. And the leader of that organization is again, a PHCA board member. We did this for a couple of reasons. One, we were tired of being abused by the national insurers. We felt like the big insurance companies, the Uniteds of the world, weren't being transparent with us and weren't paying us what we should get paid to provide care for our patients. So we started our own program. And the bottom line is it's been incredibly successful. It's profitable. It returns great returns to the operators. But more importantly, it's been great for the patients. It's lowered hospitalizations 40 to 50%, and it keeps people healthy and in our beds and not in hospital beds. So let's jump now to the main topic for today, is the nursing shortage and how significant it is. 94% of nursing homes, 81% of assisted livings are reporting staffing problems, okay? That was in June of 21. So now we're in September. We have another surge of COVID. And nurses are getting burned out. And in some states, they're talking about increasing staffing mandates. You know, the politicians, they just like headlines. The reality of staffing at these higher numbers is virtually impossible. We're having enough trouble keeping the current level of staffing. I have 2 buildings now. I've sold most of my buildings, but I have one in Philadelphia and I have one in central Pennsylvania. My Philadelphia building has tremendous trouble getting staff. And we've actually stopped taking admissions because we couldn't find enough staff. And that's really problematic in the long run. You can do that for a few weeks, and that's what we're going to do. But you know, you not only have to provide staff, you have to provide quality care, and you have to stay out of regulatory trouble by providing the kind of care that patients require. So it's a huge problem. COVID's made this worse, and as the state and federal government puts COVID vaccination mandates in place, it's not going to get easier. I'm all in favor of every single person in this country should be vaccinated, particularly healthcare workers. And I'm in favor of a national program to require all healthcare workers to get vaccinated. But that's not what we've seen so far. We've seen a focus on nursing homes getting employees getting vaccinated. That runs 2 risks. There's the general risk of people leaving and staff leaving because they have to get vaccinated. And there's the double risk that they'll just go work somewhere else in healthcare because this mandate is only applying to nursing homes. So this is going to get worse before it gets better. And the politicians are more impressed by headlines than what will really happen when they come down with various mandates. It's a huge problem. One of the reasons for the problem, by the way, and we should comment on it a little bit, is years ago, we used to have diploma nurses and bachelor's nurses. And the programs, the nursing, let's see if I can find back to our slide here. You know, the leadership of the nursing academic world decided that we should only have bachelor's programs, and they closed most of the diploma schools all over the country. Now, for those of you that are old enough, like I am, to remember the diploma schools, those nurses came out with great clinical training. They were typically in hospitals. They got lots of clinical training. They probably got a little less academic training. They were good hands-on RNs and LPNs. We've lost all of those. And now what we've got is just the bachelor's programs, and they don't pump out enough nurses, and they won't pump out enough nurses for the foreseeable future. So we have a problem with nurses at the LPN level and at the RN level, and we have a huge problem, obviously, with other staff in the building, including aides and food workers and everybody else. So the question then is, how can we use the value-based programs and the resources they bring to help us do a better job despite this tight nursing situation? You know, the politicians are going to have to get together and work with the industry and leading folks that are running our trade organizations and solve this problem. In the meantime, we all have buildings to run. And the question is, what do we do to solve some of these problems, make it easier on our staff, and pick up the problems that are occurring in patients before they get sick and go to the hospital? Because there's a direct corollary. Lower staffing, more transient staffing, which is what we're getting, are going to lead to more gaps in care. And how do we prevent those gaps in care from occurring? Just to give you an idea of where the staffing problems were the worst. And what's interesting about this graph, it's, you know, Pennsylvania is in a dark color. That's actually less of a problem than a California or a Nevada or a Texas that's got an even lower number of nurses for the population. And yet, states like Pennsylvania are really hurting. Texas and California and Nevada are just getting crushed. So it's a problem all over the country, and even the best states are having a problem. Okay, so let's talk about how we use value-based care. Here's the premise behind value-based care is interesting. And that goes for ISNPs and ACOs and everybody else. The premise is if we can provide better hands-on care in the nursing facility, better preventive care, we can pick up things earlier, then we can prevent hospitalizations, okay? And to do that, they supply certain services. And we'll talk much more about the services, but the biggest services are nurse practitioners and nurses that come into your building and add to your clinical team. And they do lots of things that are going to make it easier for your director of nursing, easier for your QA nurse, easier for your ADONs, and even easier for the nurses on the floor. When Mrs. Jones gets really sick at 3 in the afternoon, and the shift change is right about to occur, and it's a fire drill trying to figure out how to get Mrs. Jones to the hospital, everything else gets ignored for an hour and a half. You know, she's short of breath, she needs oxygen, she needs this, we got to call 911, somebody's got to stand next to her, somebody's checking vitals every 5 minutes. You don't have the staffing for emergencies. You want to prevent emergencies. What you really want to prevent them is 2 or 3 days earlier. Mrs. Jones hasn't had a bowel movement for 3 days. You want to know that, okay? You want to know that because if you know that and you give Mrs. Jones some Colace, she doesn't get septic 3 days later and create that fire drill for an admission. Or another patient with a history of heart failure who gets their feet get a little swollen on Monday. You want to pick it up on Monday, not on Thursday. On Thursday, they're in acute pulmonary edema. They've got oxygen. They're having chest pain. Again, it's the fire drill. If you prevent that problem with a little bit of Lasix on Monday, you never have that issue, and your staffing on Thursday is not as bad. So think of anything you can do to prevent that hospitalization as being a reduction of workload for your staff, okay? So let's talk about what an iSNP is in particular, because that's the most accessible of the Advantage plans for your facility. You know, of Advantage plans or other value-based programs for your facility. It's an insurance plan that partners with your facility to reduce hospitalizations. The reason they want to lower hospitalizations is to reduce cost. They use nurse practitioners, they use nurse coordinators and data mining. They use all kinds of different methods. At PPHP, we've gotten very deeply into data mining, and we use a software called Real-Time that we're also involved with, which if anybody's interested, we can talk about. But the bottom line is the iSNP has reduced admissions 40 to 50%. That's 40 to 50% less fire drills that we have to deal with, okay? So what do we do at our iSNP? And I'll talk about a little bit what other iSNPs do as well. All iSNPs provide nurse practitioners. So it's another clinical person who comes into your building. They're typically a registered nurse. They may see the patients once a week. Our NPs see the patients almost every day. They duck their nose into the room, they talk to the nurses who's having a problem, and they get in there and they look for ways to prevent hospitalizations. Every iSNP does that, has nurse practitioners in some function. We added 2 things to that mix, and a lot of this was out of the leadership from Quality Life Services and from our own team. We added nurse managers, and those nurse managers basically become care coordinators. They help schedule appointments, they help look at the diagnosis of the patient, they coordinate lab work, they do all kinds of they look at all kinds of topics that the nurse practitioners who are more like treating physicians don't have as much time for, okay? Between the nurses and the nurse practitioners, we provide a 24/7 call option. So when somebody gets sick, your folks have somebody to call that responds right away. And it's just one person to make that call to, and it makes it really easy. We also do something that the other iSNPs typically don't do, and that's 24/7 electronic monitoring of the chart. And what I mean by that is a software that goes into point-click care or into AHT or into matrix care and asks hundreds of questions every hour. Who hasn't had the bowel movement? And I talked about that scenario a few minutes ago. Who has a history of heart failure and gained 3 pounds? Or somebody wrote in their note, Mrs. Jones had a great day today, ate all of her food. Her daughter came to visit, she went to therapy, her feet are a little swollen. That nursing aide, who might be from an agency or has switched floors or has only been working with you for 2 or 3 months, that nursing aide doesn't know the history of that patient necessarily. And to have the system figure out that something is new for that patient. They have a long history of heart failure and they have swollen feet. To me, that's a trigger for that nurse practitioner to walk in the room. So you can use automated data mining like a Real-Time, that system, and look for those incidents. That gets fed to the NPs, that gets fed to the charge nurse. it gets fed with protocols, and they respond to it. And the overall effect of all of this, the nurse practitioner, the care coordinating nurse, and the data mining, is that 40 to 50% drop in admissions and that 40 to 50% drop in fire drills that your folks have to run. Anybody who's been on the clinical side of nursing home knows how disruptive those admissions can be. And it's just a mess on your hands. The other thing that these data systems can do is look for outbreaks of pandemic, whether it's COVID or the next pandemic, 5 to 7 days in advance. They start picking up the little signs, and you can you can start doing your cohorting of staff and isolation and all the things you need to do to prevent a real bad outbreak in your building. How else can an iSNP help? Well, one of the problems right now is census is down. Staffing costs are up because you're paying for agency where you didn't before or overtime where you didn't before. There's dollars to be made by these iSNPs. Basically what happens is by working with the iSNP and reducing the admissions, the savings that's generated gets shared with the buildings. And one of the reasons we started our own plan between us and Quality Life Services is we wanted transparency on what savings there really was. We would see a payment from one of the big national companies, and it was never what was promised, and it was never on time, and it was always argued about, and it never seemed like we got appropriately paid. By creating our own program, we can see the exact cost of hospitalizations. We know what we're spending. We can add extra benefits that help the patient, and we'll talk about those. And then we can also reduce lost revenue because the patient's in the hospital and not with us, or they died and they're not with us. If you can prevent those reasons for going to the hospital, those emergencies, you keep your census higher too. And that's a huge plus for the building, okay? So let's talk a little bit about the clinical model for a minute, okay? And I've already mentioned a bunch of this, but it's worth reviewing. The nurse practitioners create a plan of care, and the nurse care coordinators create a plan of care for each patient. They look for that early identification and treatment of acute changes. They improve the communication with the family. One of the big things that causes hospitalizations is just communication with family sometimes. You know, the family's not always that involved. They show up on a Sunday afternoon and mom looks worse than ever and they demand an admission to the hospital. Well, sometimes those admissions aren't even necessary, but they take somebody out of your bed, they create an expense, and that patient may or may not come back to you because now the family has lost confidence in the nursing home. So these care coordinators are constantly communicating with the family and saying, your mom's got a history of heart failure, we're adding a little Lasix, we're hoping to keep her out of the hospital, she's doing just fine. And that helps reduce admissions as well. So this next slide is, that you see with this, all these little circles and such, is just a representation of the clinical model. You've got a member, you've got management of their prescription drugs, you got nurse practitioners and care coordinators and electronic medical records and data mining, and we've talked about all of that. The role of the nurse practitioner is pretty aggressive. That nurse practitioner comes in the building, they come every day. Either the care coordinator or the nurse practitioner is there every day. They make rounds, lightning rounds on the patients and see virtually every patient, if not all of them. They assess and treat things, they manage care. It's as if your physician was coming into the building every day and was tremendously interested in what was going on with the patients. We all know that it is difficult to get the docs into the building every day. We know it's difficult sometimes to just track them down at all. So when you know you've got a nurse practitioner coming in, acting as the physician, they're there every day, the nursing staff gets used to working with that person, the docs become a little less involved, and the NPs end up solving a lot of the problems in real time. They're not waiting 3 days or 5 days or 7 days. And they know the patients and they're part of the 24/7 coverage. It is just flat out better care. And when you tell potential residents or their families about the fact that you've got an NP that sees that patient every day, they're more likely to choose you over the 3 competitors. And we have seen that in all of our markets. You know, a big part of the marketing of the nursing homes that we work with is them to be able to say, we got a care practitioner, a nurse practitioner who sees your mom or your dad every single day. That's a big plus. The care coordinator, again, makes rounds. They look at patient at risk. They look at the advanced directives. They look at scheduling and setting up whatever other care they need. They coordinate with family and the team in your building. And they look at hospital discharges and plan of care to make sure everything's in place. They also work with benefits. The other thing they do is they make sure that the plan knows all the diagnoses so that it gets paid the maximum dollars. The more the plan gets paid, the more the facility gets paid. Because remember, the way and we'll talk about the economics of these plans in just a second, okay? Because it really is important. If the plan gets paid what it deserves to get paid because they know the patient has diabetes and renal failure and peripheral vascular disease, that ends up translating into revenue for your building as well, and that's important. The other thing these plans can do, because they're allowed to use those Medicare dollars that are being saved in other ways that benefit the patients, they create new benefits for the patients that they really like. It's things like dental care, a companion that goes with them to doctor's office appointments. You know, we've always sent somebody who sort of went with them who knew nothing about the patient. We actually can afford to pay for somebody who knows the patient care and can go with them and coordinate the care when they come back to the facility. You know, health aid can go with them, podiatry, hearing, vision, transportation. There's some over-the-counter things they can order, gowns and clothes and things for their room. And in many of our buildings, they can get hairdresser appointments. For the little old ladies that we take care of, that's a big deal, and that gets paid for by the plan. You'd be amazed how many family members see that as one of the biggest benefits. So let's talk a little bit about the financial model, and I don't want to get too crazy about it. But the bottom line is that CMS spends a certain amount of money on every one of our patients every day. Now remember, these patients are the long-term care patients in your nursing home, not the short-stay patients. The plans, the ISNPs enroll patients that have been in your buildings for at least 90 days. The building is being paid by Medicaid, that's the state, not Medicare. But they all have Medicare, virtually all have Medicare benefits. They're called dual eligible patients. They almost all have Medicare as well as Medicaid. And Medicare, which is the ISNP program in this case, it has to pay for hospitalizations, doctor visits, medications, medical equipment, those sorts of things. Physical therapy, all that gets paid by the Medicare side, not by the room and board under the Medicaid program that the state pays for. So there's about $2,200 a month, you see that up at the top of the slide, that CMS will pay the plan. And out of that, the building, the first thing that comes off the top is a monthly fee to the building for helping to take care of that patient. It's a care management fee. It's to cover things like physical therapy and just the extra work that has to be done by the staff. It's a huge payment. It's about $500 a month, $530 a month. Then the plan pays. You can see here, that was that first payment. Then you can see here where it says medical and drug claim costs, the hospital costs, other Part A and B costs, the drug claims. That is interesting. That's only $878 out of that $2,200. And the reason it's so slow is that these plans are so successful in reducing hospitalizations. The biggest driver of cost for these patients is hospital days. A hospitalization can cost $10,000, $20,000, $30,000. Every time you avoid one, it frees up dollars to do other things for the patient and for the building. So you see those costs. And if you add up all the costs so far, that's called the medical loss ratio, that $1,400 number you see. That's the payment to the building, the base payment to the building, and all the actual costs of care, okay? Then you add in about $330 to pay for the nurse practitioners. That gets paid out of the dollars that we didn't spend on hospital care. So that gets paid out of there. And then something very interesting occurs. If you didn't spend up to 85% of the total capitation out of that $2,200, federal government has said 85% of that $2,200 has to go to direct care expenses for patients. So most of the time, the buildings don't spend that much. Between the hospital days, the nurse practitioners, and that base payment to the nursing home, you still haven't spent that 85%. Those remaining dollars, and in this case about $330 in this example, also goes to the building. The management of the building decides how to spend those dollars. They can increase staffing with it. That's a nice thing. They can pay for those agency nurses we're sometimes stuck with. They can pay overtime to our own staff. They can do all kinds of neat things with those dollars, and they do. It's a huge additional revenue stream. If you're getting a total of $550 and $330, that's $860. $550 and actually the number is pay for performance $132. That's $682 per patient. If you've got 50 patients involved, that's $30,000 a month of additional revenue to the building that can be used for staffing and salaries and everything else. It's a very tight environment for nursing home costs and expenses. It's a great additional revenue stream. And so you can use those dollars for that. And typically that's what our buildings are seeing. You know, and not just us. I mean, iSNP in general has been very successful. Let's talk about improved facility revenue. And we came up here with just an example of what 70 members in a building, which is about typical, in a building enrolled in one of these plans would do for a facility. And what you see in these circles is, depends what the total cost of care is. Remember I told you have to spend up to 85 cents. You're required under the Affordable Care Act, you have to spend 85 cents. So if the actual cost of care, the hospitalizations, the nurse practitioner, the bonus, the base fee to the building is at 79 cents, 79%, you see that here. The building ends up bringing in $556,000. And you see that as the green wedge in that first circle. And as that cost goes up, you see that the building payment goes down. But typically the buildings are in that 79% range and they see $500,000, $600,000, $700,000 of new revenue a year. Again, as you can imagine for your facilities, that's a big deal. Okay, so let's go back to the original topic. iSNP partnership improves quality in the current nursing home staffing crisis. There is no question that partnering with an iSNP, bringing a nurse practitioner and a nursing care coordinator is going to help your facilities take care of your patients in this staffing crisis. You've got more hands seeing the patient. There's nothing worse for a director of nursing to have a survey and have a surveyor tap them on the shoulder. They turn around and the sentence from the surveyor starts with, "Did you know?" As staffing gets worse, there's more "did you know" moments. That never ends well. I've been involved in hundreds and hundreds of surveys. That "did you know this" or "did you know that" about your patient, and they wouldn't be asking you if you knew. And that never goes well. So the more eyes we can put on the patient, the more eyes we can put on the patients early, not when they're already an extremist and have to be shipped to the hospital, but when we're in preventive care mode. Seeing that patient 3 days before that heart failure admission, or 3 days before that impaction admission and sepsis. That's really a help. So to have that NP and that RN care coordinator see that patient every day, it's a big deal. We think our clinical monitoring using the real-time software program also adds a huge amount to these patients. That software alone has been shown to have dramatic impact on reduction of admissions. And again, it reduces those "did you know" moments, okay? And then the last area, and we talked about that at length in the end, the additional revenue to the building. That can be better salaries for your staff. That can create loyalty in your staff. That can be to pay for other services for the patients. That can be just to keep the mortgage up to date, because buildings are having trouble. Some of our biggest chains are having the most trouble right now. So all of those are ways that you can partner up with an iSNP to help prevent problems in your building, to reduce the clinical struggles that you're in, and to improve the revenue side of the facility. iSNPs, as I mentioned before, have been incredibly successful nationally in reducing these issues. There are still folks that are resistant to them. There are still folks who believe that they can just extend length of stay and that those forces are more important than these forces of quality. Like it or not, CMS is pushing everybody to value-based care, because value-based care is achieving what's best for the patient, which is less admissions and less cost. where churning folks in and out of the hospital and trying to extend length of stay has the exact opposite effect. And the CMS folks, they're slow, they're plotting, but they're smart, and they know where they're pushing this. And they've had a remarkable impact. 50% of the patients in this country on Medicare are now in some sort of value-based program. And that number will be 80 to 90% within 5 years. It's not, every facility ought to be learning how to do these things right now, because that's the future formula for success. So I'll end it there. If anybody would like to be in contact with us or ask questions, we're happy to answer them. Here's our contact information. And again, it's been such a pleasure to be here before you all and talk about these topics today. Thank you so much.